today I'd really like to talk about just specifically post-operative protocols, and then what happens for those select few patients that have continued wrist pain after surgery, and how do we manage their expectations and satisfaction so they can continue to participate in their daily lives. So really the goal of therapy is, after any surgery, is we want pain-free range of motion. We need that range of motion to be functional so they can continue to do their daily activities. I want them to engage in all those meaningful occupations, and my biggest thing is I want a satisfied patient in my clinic. So when I look at after a TFCC repair, I think of 4 stages of rehabilitation. So stage 1, I'm going to look at immobilization, but then we're looking at proximal stability. Stage 2, that's where we're going to start restoring that wrist and forearm range of motion. Stage 3, proprioceptive rehabilitation, is one of those more of a buzzword in our clinic these days that we're finding is a key to making these patients have a more stable wrist and allowing them to go back to their daily activities or their sports professions. And then stage 4 is really looking at strengthening function and what type of activity modification do we need to have them do as well so they don't put increased stress on the TFCC repair. So when I look at my stage 1, after they come out of a TFCC debridement, typically they're immobilized for the first 4 to 6 weeks. If they have more of a peripheral TFCC tear or a UT split tear, they're going to be immobilized for 6 weeks. Well, what do you do during that time while they're in that cast or that post-surgical dressing? For therapy, it's really critical that we make sure that they have excellent finger range of motion. But now we also want to make sure their proximal joints that are free can move as far as they can. So keep that shoulder full passive range of motion, full active range of motion, but also looking at proximal stability exercises. So just simple things such as having your patient squeeze their shoulder blades together. That's a really nice exercise to get them to start increasing that upper back strength, which in turn will help offload the wrist down the line. So other things I can do is, for some of my patients that don't have great stability, and again, I'm going to do that shoulder retraction, but maybe for my professional athlete or some of my young kids who are more athletes, I might have them go more into a prone position or on their stomach, and we're going to do what's called I's, Y's, and T's. And again, that's just going to help strengthen that back. After that first 4 to 6 weeks, depending on the type of repair, they come out of a cast, and that's the day we're going to start restoring their wrist range of motion and also looking at splinting. So at that first session, again, I want to educate that patient that all these exercises need to be pain-free. I don't want them to have pain. That was why they had surgery. And so I also have to help them distinguish that sharp pain is not okay, but a little pull or a stretching type pain is okay. In our clinic, I try to avoid using any type of use of a hammer for supination and pronation because it can increase the strain on the TFCC, and I'd hate to do anything to disrupt the repair. It's also critical that we look at scar management at this time because regardless of how the repair was done, if you have those dorsal portal incisions, that can limit your wrist flexion if that scar adheres down to underlying structures. And so that's can also be one of the harder motions to get back. And then we also really need to make sure they don't have edema in that wrist or forearm or the fingers, because that edema can later get brawny, and that will limit our motion and give us a poorer result down the road. As we continue to look at wrist range of motion and restoring that, we just don't want to go in those planes of just standard flexion and extension and maybe ulnar and radial deviation, but we want to do something that allows a circumduction of the wrist envelope and maybe even doing dart throwing, because that's going to help get some of that nice motion back. So in our clinic, we make little different tools for the patient to help do that wrist circumduction envelopes and normalizing normal wrist motion that they would need for everyday activities. while they're still at that first visit, we need to talk about immobilization coming out of a cast. In our clinic, typically we'll put them in a Munster splint, which is the one with the nice white. It goes above the elbow. There's a variety of ways to make that splint. And then for some of our surgeons, once that patient achieves 45 degrees of supination and 45 degrees of pronation, we're going to go ahead and we're going to transition them just into a prefabricated wrist support, or it could be a custom wrist support. Another thing you could do is if you made a Munster splint, you could just allow the elbow to be free. And so that's an important discussion that therapists should have with the surgeons or vice versa. And the other nice thing is if the patient gets more painful, they can go back to the larger splint. If they're doing well, they can continue with the smaller splint. Some of the questions we've had in our clinic is, okay, my patient comes to me, they got out of the cast today, and now they already have that 45 degrees of supination and pronation. What should I do? We're still going to put them in a Munster splint for at least 14 days to slow them down prior to putting them in a wrist splint, if that's what the surgeon allows. And then on the opposite end of the spectrum, we have those patients that they still don't have that 45 degrees of motion for supination or pronation at 10 to 12 weeks. And what should I do at that point? I'm just going to try and wean them from all splints at that time as pain allows. So looking at that next stage and of stage 3, that's proprioception, and that's very important in our clinic. And one of the reasons why is when wrist ligaments are injured, they have a really hard time understanding the ligaments, understanding their joint sense or their joint position in space. And so there's different treatment techniques that you can do out there. And one of them is just having passively putting the patient in a certain degree, taking them out of that motion, and then having them try and replicate where I position their wrist. Another thing to help try and improve their wrist range of motion is this is a little tool. It's called, I believe, True Balance, and it just helps get that proprioception where they're supposed to stack all these circles up on a line. So sometimes an activity is more fun than doing exercise for our patients. And then when do we begin strengthening in our clinic? Well, typically I begin strengthening when the patient has 90 degrees of their motion back. And then we go ahead and we're going to start with isometrics, advance to resistance bands or weights. And then from there, you can simulate more work type activities. We have a BTE where it's a machine that can help calculate and simulate work activities for some of our patients. And again, I avoid anything with a hammer because I don't want to jeopardize the repair. During the strengthening phase 2, I'm going to continue to advance my proprioception. And so this is really important where I'm going to continue to do those coupled motions, like I said, and then I'm going to do closed chain exercises. So that might be where I'm going to put a ball on a wall, and then with that ball on the wall, I'm going to do some circles, or I'll write out the alphabet. From there, we can go into using a gyroscope or using what we call as a body blade, which is this middle one. And that just helps, again, helps strengthen and helps the ligaments with that stability and decrease that wrist pain for us. Also during this phase, I want to talk to my patients about avoiding excessive gripping, wrist loading, repetitive forearm motions, and maybe prolonged end range of motion in supination or pronation. A lot of times my patients come back and they say, I want to do push-ups, or they want to do yoga and they want to get into their downward dog or their chaturanga positions. And those aren't always the best. And so how can we neutralize any increased load on the wrist? So it might be using power tools, or it might be doing push-ups or certain yoga positions and keeping the wrist more in a neutral position versus having it all the way extended, or using adaptive aids to help open jars versus use all my hand strength. In therapy athletes, therapy will start going to that sports specific training. Again, once about 90% of their strength has come in, and that's when I'm going to work with their trainers or their coaches. And for some of the elite athletes, a lot of times you have to talk to them about pain versus fatigue. And we don't want them to go into pain, and they think no pain, no gain. And that's not the case in this type of rehabilitation. So often in my experience, wrist flexion and supination are the hardest motions to get back. It's imperative that we do good scar management over all the surgical portals. And from there, what happens if my patient has persistent wrist pain? What do I do next? I want to scream a lot of times at these patients because I get really frustrated with them too, but I'm probably going to talk to you and I may see your face do this. But I think really as a clinician is managing that patient's expectations is how long has it been since surgery? Is that pain related to only a certain activity and can I modify that? Can I have them do icing or heating at home? If I can't figure it out, I may refer them back to the surgeon for that, but also I might consider doing some different type of taping techniques or using a wrist orthosis or a wrist strap to see if that can help manage my pain. So in summary, really work with your hand therapists. We're going to work as a team to get that patient through this rehabilitation progress. Often you want to progress slowly after surgery and let pain be the guide. Proximal stability, getting that shoulder and upper back stronger is a must in this type of rehabilitation. Start trialing that proprioceptive exercises to increase the stability of the wrist, and then really set realistic expectations for your patients. So I'd like to say thank you for this opportunity to talk.